A bicortical pedicle screw in the cephalad trajectory is the best option for the fixation of an osteoporotic vertebra. A finite element study. There are no conflicts of interest with any company or other entity that need to be disclosed in relation to the presentation of the abstract. Pedicle screw loosening is a highly prevalent complication that can result in unfavorable surgical outcomes associated with the loss of spinal alignment or pseudoarthrosis, particularly in patients with osteoporosis. The anchoring ability of pedicle screws depends on the strength of the bone-screw interface. Thus, biomechanical studies have been widely conducted to elucidate the factors related to fixation strength, including the morphology of the pedicle, mechanical properties of pedicle screws, and insertion techniques of pedicle screws. Purpose is finite element analysis to explore the optimal depth and trajectory of pedicle screws in the osteoporotic vertebrae. From our database of lumbar spine surgery, 18 female patients aged 55 to 91 years whose bone mineral densities were measured preoperatively at the femoral neck and spine via dual energy X-ray absorptiometry were selected. The patients were divided into two groups using the Hounsfield unit, O group consisting of patients with osteoporosis, and No group consisting of patients with no osteoporosis. The measurements in the spine with severe degenerative changes were inaccurate. Thus, the Hounsfield unit was used as a substitute, which exhibited correlation with bone mineral density. The Hounsfield unit values were measured on preoperative computed tomography images by placing an oval region of interest over 3 axial slices of L3, immediately inferior to the superior end plate, in the middle of the vertebral body, and superior to the inferior end plate. Three-dimensional finite element models of the L3 vertebrae were constructed using the preoperative CT images of the lumbar spine with a slice thickness of 1 mm. A pedicle screw with a 7.0 mm diameter was modeled using the CT data taken via a high-resolution micro-CT. Pedicle screws with two different lengths were inserted into the vertebrae, unicortical screws to the center and bicortical screws to the anterior cortex of the vertebrae. The pedicle screws were inserted in 3 different trajectories in the sagittal plane: caudal trajectory toward the anterior inferior corner of the vertebra, straightforward trajectory parallel to the upper end plate of the vertebra, and cephalad trajectory toward the anterior superior corner of the vertebra. 3 different external loads were applied to the pedicle screws at the entry point, with the models completely constrained in all directions at the surface of the upper and lower end plates of the vertebrae: axial pullout, craniocaudal, and lateromedial loads. Results. Table presents the fixation strength of the pedicle screws in the O and No groups against each external load for each depth or trajectory. In both groups, the bicortical pedicle screws had greater fixation strength than the unicortical pedicle screws in all trajectories and external loadings. Therefore, the optimal trajectory and impact of osteoporosis on fixation strength of bicortical pedicle screws were investigated. In the No group, the fixation strength of the pedicles was approximately 2 to 3-fold greater with statistically significant difference in all trajectories against craniocaudal load compared with the O group. In the No group, the fixation strength of the pedicle screws was not statistically significantly different between the trajectories for any of the external loads. However, in the O group, the fixation strength against the craniocaudal load in the CE trajectory was statistically significantly greater than those in the CA and SF trajectories, although this trend was not observed against the axial pullout and lateromedial loads. In the No group, the fixation strength of the pedicles was approximately 2 to 3-fold greater with statistically significant difference in all trajectories against lateromedial load compared with the O group. In the no groove, the fixation strength of the pedicles was approximately 2 to 3-fold greater with statistically significant difference in all trajectories against axial pull-out load compared with the O groove. The equivalent stress distribution around the bicortical PSs in each trajectory against external loads is presented in figure, with the red area indicating stress concentration. The pedicle mostly contributed to the fixation strength of the pedicle screws in all trajectories against craniocaudal load, but in the CE trajectory, the anterior cortical bone layer at the screw tip exhibited a relatively higher stress distribution against craniocaudal load than those in the CA and SF trajectories. The pedicle mostly contributed to the fixation strength of the pedicle screws in all trajectories against lateromedial load, but in the CE trajectory, the anterior cortical bone layer at the screw tip exhibited a relatively higher stress distribution against lateromedial load than those in the CA and SF trajectories. The pedicle mostly contributed to the fixation strength of the pedicle screws in all trajectories against axial pull-out load, but in the CE trajectory, the anterior cortical bone layer at the screw tip exhibited a relatively higher stress distribution against axial pull-out load than those in the CA and SF trajectories. Discussion. The axial pull-out load was traditionally applied to assess the fixation strength of pedicle screws in biomechanical studies. However, a recent cadaveric study reported that non-axial loads applied to pedicle screws caused screw plowing, which led to subsequent screw loosening. Finite element analyses also revealed that axial pull-out did not substantially contribute to screw loosening and that craniocaudal loading increased the risk of screw loosening in the osteoporotic vertebrae. The cortical bone layer exerts a substantial effect on the fixation strength of pedicle screws. In addition, the strength of the vertebra screw interface is associated with the regional bone density around pedicle screws. In the osteoporotic vertebrae in our cohort, the bone density at the screw tip of the pedicle screws in the CE trajectory was greater than those in the CA and SF trajectories. Therefore, bicortical pedicle screws were recommended in the CE trajectory for the osteoporotic vertebra, although the trajectory did not affect the fixation strength of pedicle screws in the non-osteoporotic vertebra. First, the external loading conditions do not accurately reflect clinical loading conditions. Surgically embedded implants including pedicle screws are exposed to repetitive biomechanical stresses inside the body due to the patient's daily movements. Therefore, cyclic loading to pedicle screws might be needed to assess fixation strength in vertebral models. Second, the insertion techniques did not completely reflect those employed in clinical settings, in which the pedicle is probed and a tapping hole is created. Finally, models with instrumentation at multiple vertebrae were not used. In conclusion, our results indicate that bicortical pedicle screws should be selected for spinal instrumentation in patients with and without osteoporosis. In patients with osteoporosis, pedicle screws should be inserted in the trajectory toward the superior anterior corner of the vertebra.